GLP-1 receptor agonists, which are quite topical because everyone online and celebrities and in the media, they're talking about the shortages of these medications as well as the implications that they're having because of their uncontrolled use. So today we'll kind of be going through what is GLP-1 as a molecule, what are these receptor agonists, how do they work, different types, and the implications kind of in healthcare and how they're being used in different situations. So, to start off with, let's just talk about what is GLP-1. So, GLP-1 stands for glucagon-like peptide 1. It's produced by these L cells, which are a type of cell found in the lining of the small intestine, and their release is mainly stimulated by food. So, when food enters the stomach, it kind of triggers these pathways to release GLP-1 from the small intestine. And if you think about kind of the implications of having too low or too much of this molecule, so on the right of the screen, it just kind of outlines some of the effects that it has on different organs and different systems. So you don't need to know all of that, but just for some context, it has like systemic effects in a lot of different areas of the body. And that will kind of make a bit more sense as we go through the session. But if you don't have enough GLP-1, then you actually have an increased risk of obesity. And this is because it kind of helps to make you feel a little bit more full and have this kind of increased satiety. So that means that you don't keep on eating and eating and eating once your stomach is full. And obviously, if you don't have that kind of restriction on your calorie intake, then obesity is much more likely to occur. And then if we think about excess GLP-1, then that can often help to control blood sugar in patients with type 2 diabetes. And this is where our GLP-1 receptor agonists, which are the medication that actually help treat type 2 diabetes and obesity, that's where they kind of come in to kind of supplement the GLP-1 levels in order to make sure that you're not kind of having these really severe symptoms of type 2 diabetes and you're able to control your obesity as well. So, yeah, cool. So, moving on, let's talk about the incretin effect. And this is basically kind of putting things into context in terms of how it actually works for obesity and type 2 diabetes. So, GLP-1 actually belongs to a family of hormones called the incretins, and these molecules enhance the secretion of insulin. So, that means that they basically encourage the release of insulin from the pancreas. And as you guys probably know, or this might be in year two, I'm not entirely sure. But essentially, in the pancreas, you have different types of cells. Beta cells release insulin, alpha cells release glucagon. And GLP-1 actually increases the volume of beta cells in the pancreas so that you're having more insulin released. And then you're also inhibiting glucagon. And remember, insulin decreases blood sugar levels, glucagon increases blood sugar levels. So overall, by inhibiting glucagon, you're not letting your blood sugar rise, and by stimulating insulin release, you're making sure that blood sugar is dropping. So those two kind of work together to make sure you have an overall lower blood glucose level. And also that it also has an effect on increasing satiety. So as I mentioned, it kind of makes you feel a bit more full, makes you not overeating. And this is because it acts on the appetite centers of the brain. And it also does this thing called gastric emptying. So it reduces gastric emptying of the stomach, and that means that the food stays in your stomach a bit longer. It takes longer to digest fully and go through the system. So that means you have that food present in your stomach for longer, and that makes you feel more full anyway. So on the diagram on the right, it's just kind of a little pathway. Again, a lot of detail, but essentially the bottom line is that you have an enzyme that activates incretins and incretins themselves. So GLP-1 is one example of this family of hormones. Another one is GIP, and it basically stimulates insulin, inhibits glucagon, and those two things work together to make sure you have a lower blood glucose level. And that is obviously very important in managing type 2 diabetes. And it also plays a role in satiety, so that helps you target obesity and kind of overeating problems also. So, moving on, now we'll talk about what actually are these medications that act as GLP-1 receptor agonists. And first of all, I think it's just important to clarify what this kind of terminology means. So, an agonist is kind of any molecule that binds to and activates a receptor. So, you will have these GLP-1 receptors throughout the body. They're like concentrated in certain areas, but they are found in many different areas of the body. And if you have GLP coming in binding to this receptor, the GLP is acting as an agonist for this receptor. So, an analog is a type of agonist. So, when we're thinking about the medications that we're using under the umbrella term of GLP-1 receptor agonists, the majority of them are actually GLP-1 analogs. And an analog is a type of agonist which actually mimics the action of natural native GLP-1, but it has some modifications to make sure that it actually has an effect that is therapeutic and helps alleviate those symptoms. So, for example, is resistant to degradation by DPP4, and that's just the enzyme that breaks down your GLP-1. And it also means that there's another modification that allows it to be eliminated slower from the body. So it stays in the body longer, doesn't get degraded as quickly. So that means it's longer acting and it basically can have its effects in terms of increasing satiety, lowering blood glucose for a longer period of time. And obviously, that's what you need when you're thinking about having that therapeutic effect, decreasing the symptoms of type 2 diabetes, and also having an effect on obesity. So I hope that makes sense. An agonist is just any molecule that binds to a receptor. So in this case, it would be GLP-1 binding to your GLP-1 receptor. And a GLP-1 receptor agonist is your medication umbrella term. GLP-1 analog is the majority of these medications, and they're a type of agonist which very closely mimic the action of GLP-1, but with modifications to make sure they can actually have a longer lasting effect. So, yeah, we can move on now to think about what actually are the effects of these receptor agonist medications in the body. So, if we kind of focus on these four main areas, so you have the organs on the right side of the screen. So, insulin, starting off with the pancreas, thinking about how the body is going to be able to produce more insulin when it's needed. Because remember, insulin lowers blood glucose. So, if you eat, you need to release your insulin to make sure your blood glucose is being lowered back down to your normal level. And in type 2 diabetes, obviously, you have this insulin resistance, and you also sometimes just don't produce enough insulin. So that means that you have higher blood glucose, and you need your pancreas to help your body release more insulin when it is needed in response to meals and things like that. So, native GLP-1 releases your insulin from the pancreas when your blood glucose levels are high. So after a meal, for example. And then when you have these receptor agonist medications, it means that you're able to basically have a more stable and longer lasting effect on the pancreas cells. So they release insulin for a little bit longer, they're a bit more stable, and that obviously helps you keep that blood glucose level low when you have high blood glucose because of your type 2 diabetes. Um, and if we move on to the liver next, they GLP-1 receptor agonists kind of reduce the amount of sugar that's produced by the liver. So if you think about when we spoke about GLP-1 inhibiting glucagon release, so glucagon actually stimulates things like glycogeno no, yeah, sorry, glycogenolysis and gluconeogenesis. So those are kind of processes that take place in the liver to help increase your blood glucose levels. And those happen in the liver. So when you inhibit this glucagon release, those processes decrease, and therefore you're not having as much sugar produced by the liver, either in gluconeogenesis, which is when you're producing it from new substrates, or from glycogenolysis, when you're breaking down that glycogen that is stored in the liver, um, basically as a long-term store. So, yeah, the GLP-1 agonists also encourage insulin release, and that inhibits glucagon as well. So basically, your glucagon is low, and that means that less sugar is being produced by the liver to keep your blood glucose levels down. So, next, if we think about the stomach and digestion, so we started touching on the fact that it kind of slows down digestion in the stomach, reduces gastric emptying. So that basically means that it takes longer for the body to absorb sugar in meals. And this means that you're not having those spikes after meals as you would do otherwise. And that basically helps your body to kind of deal with this increase of blood sugar a bit more gradually. And it basically just helps you manage that type 2 diabetes a little bit more because you're not having those spikes. Um, and the gastric emptying, just to kind of explain that a little bit more, it's the rate at which food moves from the stomach to the small intestine. And by decreasing that, again, because obviously your nutrients are absorbed in the small intestine, by decreasing the rate at which the food is moving down to the small intestine, it means that you're able to kind of more gradually absorb those nutrients into the bloodstream. And that includes glucose. So you're not having those spikes because of the slowed transition of this food from the stomach to the small intestine. And then if we think about appetite, lastly, this is where kind of the brain gets involved because your GLP-1 receptor agonists reduce your appetite and increase your satiety. So you feel less hungry and you feel more full, basically. And this is because you do have some GLP-1 receptors in your brain. So when your GLP-1 receptor agonist binds to that, that means that you're kind of stimulating the same kind of effect that you would have with GLP-1 normally. And this is basically sending signals to make you feel more full. And in combination with that slowed gastric emptying that we spoke about with the stomach, so you're kind of feeling more full because the food is in there for longer and you're having these nervous system signals. Putting those two together, you just generally have a greater feeling of fullness and a reduced appetite. And then obviously this decreases your overall food intake so that you're not overeating, your blood glucose isn't rising too much, and that helps with type 2 diabetes and obesity. Because remember, they are very closely linked. When you have these high blood glucose levels, that can kind of, they do supplement each other a little bit in terms of obesity and type 2 diabetes. So moving on from that, let me just check the chat. Why does a reduced sugar level lead to a prevention in obesity and a feeling of being more full? So, in terms of prevention of obesity, remember that if you have excess sugar in the bloodstream, that is stored as fat or converted to fat, converted to carbs in your body. And obviously, that's going to be stored in your adipose tissue and kind of perpetuating that obesity level, making you a higher BMI level and things like that. The feeling of being more full. So that's not directly correlating to the sugar level. That's more thinking about the effect of the GLP. So the GLP, remember, talks to the brain and that releases this feeling of being full. That's just an effect that it has in the nervous system. And then also it slows down digestion in the stomach. So if you imagine the food normally moves from the stomach to the small intestine, but that is slowed down. So it's present in the stomach for longer. And obviously it's physically there, so you do feel more full. So I hope that kind of answers your question. Um, why is not having spikes due to glucose a good thing, or what's the problem with spikes? So the problem with spikes is that obviously if your blood glucose suddenly shoots up after a meal, then it's going to be a little bit harder for your insulin to kind of deal with that. And because in type 2 diabetes, your insulin is struggling anyway because of the resistance, the decreased insulin available sometimes, it just means that it's harder for that blood glucose level to come down. So if you kind of have it a bit more steady, it's easier for the insulin to act on it to bring it back down to your baseline level. So that is why the spikes are not ideal. And that's why the GLP-1 receptor agonists are really useful, kind of slowing down that process, making the absorption of glucose into the bloodstream more gradual so the insulin can act on it more effectively. Yeah. So I think we can move on now to think about types of GLP-1 receptor agonist medications. So you have a few different types. You might have heard of a few of them in the news, but essentially they do kind of act in the same way. They are the same kind of class of medications, but they just have small different nuances that make them suitable for different people. So the most common one that you definitely will have heard of is Ozempic, and that's used to treat type 2 diabetes. And then they both have this active ingredient, semaglutide. So Ozempic and Wegovy both have the same active ingredient, but in Wegovy, it's at a higher dose. And that's when it's used to deal with weight management and things like that. They both are weekly injections, so that is kind of a little bit easier than having to inject insulin after every meal and things like that. So it is kind of revolutionizing type 2 diabetes treatment in the sense that it's not as high maintenance as some other treatments have been in the past. And with weight management, it's really, really important whenever they prescribe these medications to stress that if you want to lose weight, you're going to have this medication in combination with your lifestyle factors. So making sure that you're exercising, making sure that you're focusing on what you're consuming diet-wise, and only in combination with all three factors will your weight calm down and then stay down. Because obviously, you don't want to be taking these medications for the rest of your life. So by kind of supplementing it with a good lifestyle, it means that your weight won't just shoot right back up once you come off the medication. Yeah. So then moving on to the next one, exenatide. And just generally, across all of the medications, I just put it in this one. But essentially, if you have certain characteristics, it means that you're able to receive treatment from these medications at lower BMI. So right now, there's a threshold which says that if you are at this BMI or higher, or if you have this kind of extent of your diabetes or higher, then you can be prescribed these medications. And that's kind of like a threshold, a guideline to make sure that they're not being prescribed where they don't need to be prescribed. And there are certain characteristics which mean that you can be prescribed these medications at a lower threshold. And that is when you are from Black African, African Caribbean, Asian, South Asian, Chinese, and Middle Eastern backgrounds. And that is because these backgrounds, these ethnicities, are more likely to develop complications from their obesity or from their type 2 diabetes as opposed to other ethnicities. So that means that they're able to receive this medication at an earlier stage, and that kind of prevents them from progressing further and kind of getting worse and then being prescribed this medication at a stage where they may have already developed complications and things like that. So because they are susceptible to more obesity-related problems, just genetically, that is why they are kind of applicable to receive these medications at a lower threshold compared to other ethnicities. Um, and then we can talk about the next one, which is tirzepatide, and that is the brand name for that is Mounjaro. So yeah, you might have heard of that one as well. This is a slightly newer medication because it is a dual GLP-1 and GIP medication. So GIP is your gastric inhibitory polypeptide, and that's another incretin hormone that we kind of spoke about earlier. And compared to just GLP-1 receptor agonists alone, this dual class kind of medication has a higher efficacy in terms of reducing weight. And studies have shown that having them both together does make you lose weight a bit quicker and more effectively, and it stays lost, basically doesn't come back as quickly. So that's kind of a new class of medication away from your traditional just GLP-1. So in the future, they're kind of looking to incorporate more dual class, triple class, kind of thinking about how many incretin hormones you can combine to make sure that you're kind of covering all the bases and making sure that it's really effective medication. And this was actually approved for obesity in December 2024. So initially only used for type 2 diabetes, but then approved very, very recently. And hopefully this month it should be available on the NHS for treatment for obesity. So obviously that's going to help a lot of people because trials have shown that it is more effective. Again, this is another weekly injection, so quite easy to administer. And then the last one, obviously there are more, but like couldn't go through all of them, so I just picked a couple. The next one is liraglutide, and that is for weight loss and type 2 diabetes. But this one is a daily injection, so slightly more inconvenient in terms of if you have a busy lifestyle or you don't want to come into hospital because you live a little bit further away. So those kind of things influence the decision of the doctor when they're deciding, okay, which medication am I giving them? You have to think holistically in terms of lifestyle, their job, their family, if they're able to administer this injection, because you don't want to sign them up to a daily injection and then them not be able to take it. You'd rather just sign them up to a weekly injection, which they're more likely to comply with in the first place, considering their entire picture. But this one was the first GLP-1 receptor agonist suitable for children. So in terms of thinking about when you're prescribing to children kind of above the age of 10, 12, This has been the most tried and tested in that kind of age bracket because of just how long it has been used for this age bracket. Other ones are now becoming available for children, but this was the first. So obviously you can have that level of reliability and trust with this medication in that age range. So usually they will tend to go for this one when thinking about children. So above the age of 10, 12, I don't really think they tend to prescribe below that. Let me just have a look. Do the classes just refer to how many hormones are within the medication? Um, yeah, so I mean, class, I'm just like kind of using that word a bit loosely. Um, it's a new class of medication because it's not your traditional GLP-1. But yeah, you can have like dual ones, triple ones. But in terms of classes of drugs, there's a lot of different ways you can kind of categorize that, if that makes sense. So I wouldn't necessarily just allocate it to how many hormones are within the medication as a blanket statement. I hope that's right. Okay. So now let's move on to thinking about the differences. So I started mentioning things in terms of administration. So obviously, most of the ones we've talked about so far are injections, but you can have tablets, oral tablets from time to time. A few of them are available to be taken orally. So if someone really has an issue with needles or injections, then you can give them one that's oral. And then we also spoke a little bit about age in terms of which ones are more appropriate for younger children versus older people. And just having this variety of medications available means that you can really tailor the experience of the patient to their lifestyle, to their requirements, their personal kind of choices. So in terms of dosages, if again they have to have it weekly or daily, that does make a big difference. So considering the patient's lifestyle there. Considering tolerance, so some people's bodies just don't tolerate certain medications properly. So if they don't, handle one very well, you can try another one, which would be more tolerant just across the board. So you can give that a go, and just having these kind of options to play with does ensure that the patient is able to receive a good kind of standard of care and is able to be treated in the way that you want them to be. Mode of actions, that's kind of thinking about um, is it GLP-1? Is it GLP-1 and GIP? So does it target just one hormone or multiple? And dosages, like we talked about Ozempic and Wegovy. Ozempic is for type 2 diabetes, and Wegovy is a higher dose of the same semaglutide active ingredient, but that is for weight management. So when you up the dosage of the active ingredient a little bit, that then becomes a weight loss medication. So thinking about playing around with those doses to see what different effects they have, and leading on from that, thinking about the additional benefits. So there are a lot of studies being done right now into thinking about what other implications these medications can have on different parts of the body. So we'll go into that in a little bit more detail later. But just thinking about will it help the cardiovascular system? Will it help neuroprotection? There are so many different areas in which medications can indirectly have a little bit of effect. Or if there are GLP-1 receptors in different parts of the body, will it target that particular area directly? So lots of different studies being done, but it is definitely early days. So watch the space basically for the additional benefits of these drugs. So we talked about the additional benefits a little bit, but what are the actual benefits? We've spoken a little bit about reducing body weight, reducing glycemia, so that's your blood sugar levels, but it can also do things like reduce blood pressure. So that is because some of your vessels have these receptors, and that means that you have this direct effect on the blood vessels, causes them to vasodilate, and that obviously reduces your blood pressure, places less pressure on your heart, because of that decreased resistance in your blood vessels from the increased diameter. And also, sodium is really important when you're considering blood pressure, and GLP-1 actually increases sodium excretion in the kidneys. So the combination of having that reduced resistance in the blood vessels due to the vasodilation, as well as the increased sodium excretion, so less sodium present in the body. Overall, those two factors combine to reduce your blood pressure. And obviously, the other factors, like if you have a lower weight and you also have a lower blood sugar, those kind of combine to give you a little bit of an effect on your blood pressure as well. So you have the direct effects from the increased excretion in the kidney of sodium and the wider diameter of the blood vessels due to vasodilation. So those are direct effects that reduce your blood pressure, but then also reduce body weight, reduce blood sugar can also help reduce your blood pressure as well. So this is what we kind of mean when thinking about the indirect and direct effects of this medication. It reduces the blood pressure directly from acting on the blood vessels and kidneys, but then the other effects of this medication also kind of contribute to the overall reduction in your blood pressure. And then it also reduces postprandial lipemia. I hope I said that right. So that's basically the fat level in your blood after meal. So postprandial means after a meal. So if you hear things like postprandial glucose, that's just your glucose level after eating. So it actually reduces the normally elevated fat levels in your blood after a meal. And if you have high postprandial lipemia, that is a risk factor for cardiovascular disease. So by reducing the level of fat in your blood after a meal, lowers your risk of developing cardiovascular disease. And this entire thing happens because we spoke about that reduced gastric emptying. So the slowing down of the movement of food from your stomach to your small intestine. And obviously, we spoke about that in the context of reduced glucose absorption, but it also reduces fat absorption. So you're having less lipids absorbed into your bloodstream in a certain period of time. So that is again more gradual, and that reduces the level of fat in your blood after a meal. So that means that you are able to kind of improve your lipid metabolism, and that reduces your risk of cardiovascular disease. So when we're speaking about the additional benefits, that is one of them in terms of your GLP-1 receptor agonists do reduce your postprandial lipemia, and that has an indirect effect on your risk of developing CVD. Another one we can talk about is reducing inflammation. So inflammation is quite a blanket term for so many different things that happen in the body, but essentially inflammation is the precursor to so many different diseases. But this is quite a recent discovery in the sense that GLP-1 receptor agonists do contribute to reducing inflammation. And this means that it can help your heart, it can help your brain. And the way that GLP-1 receptor agonists reduce inflammation is by reducing the production of those inflammatory molecules that are released from your body. So that's basically just kind of dampens down that immune response a little bit, reducing inflammation when it doesn't need to happen. And also, that's a direct effect. The indirect effect is that obesity and hyperglycemia, so when you have high blood sugar, they are both pro-inflammatory states. So by reducing your obesity, by reducing your blood sugar levels, again, you're kind of alleviating that systemic inflammation, and that is your indirect effect because of your reduced body weight, reduced glycemia, that brings down your inflammation levels, but then you also have that direct effect on immune cells from the GLP-1. So that is basically a kind of summary of the benefits of GLP-1 in different areas and kind of like the main effects that it has on the body. Let me just check the chat to make sure there's no questions. Okay, cool. So now what we can talk about are the cardiovascular outcomes that we kind of mentioned a little bit earlier. So incidence of cardiovascular events is 3 times greater in individuals with type 2 diabetes mellitus. So that basically means if you have type 2 diabetes, you're 3 times more likely to experience a cardiovascular event. And these trials normally assess 3 main cardiovascular events, and that is death from cardiovascular causes, non-fatal myocardial infarction. So that is basically you have a heart attack, but you don't die. And then non-fatal stroke. So again, you have a stroke, but you don't die. So those are the 3 main cardiovascular events they assess when discussing these kind of trials, when discussing this research. So when they say that the incidence of cardiovascular events is 3 times greater in individuals with type 2 diabetes, they primarily mean these 3 cardiovascular events on the screen right now. And what this means is that basically because of the very close link between type 2 diabetes and this increased risk of cardiovascular events, any new medication for type 2 diabetes is also assessed for its effects on the cardiovascular system. And this is also because we spoke about the indirect and direct effects that GLP-1 receptors have on the heart and on the blood vessels, because you do have GLP-1 receptors present in the heart and blood vessels at low levels. So when you have this GLP-1 receptor agonist, it does bind to those and have an effect. So the information on the right is just a little bit of information from a paper which was talking about the effect of having these GLP-1 receptor agonists, and when you take them, what influence does that have on cardiovascular outcomes? So it basically says having this GLP-1 receptor activation might reduce cardiovascular morbidity indirectly because you're reducing your blood pressure, you're reducing your blood sugar, you're reducing inflammation, you're reducing your postprandial lipemia, which remember is the level of fat in your body after a meal, and you're also reducing your body weight. So all these factors contribute to decreasing your cardiovascular morbidity. And remember, GLP-1 receptor activation has a positive effect on all 5 of those factors, as we discussed in the previous slide. So there is a little bit at the end talking about how these medications actually do increase your heart rate, and that might not be suitable for some people with certain cardiovascular conditions which don't really cope well with an increased heart rate. So that's like left ventricle dysfunction, and heart failure and things like that. But yeah, so basically just want to highlight the close interlinkage between your cardiovascular system and kind of your glucose, and how there are indirect and direct effects from these GLP-1 receptor agonists in the cardiovascular system. And because of this increased incidence between having type 2 diabetes and also having these cardiovascular events, it's really important that whenever people assess medications, they make sure they look at cardiovascular outcomes as well. One, to make sure it's not actually damaging the heart or the cardiovascular system in any way, but also making sure that if there is any kind of positive outcome that might come out of it, they're able to identify it, and, maximize it. So, yeah. This is a little kind of diagram talking about some of the effects of GLP-1 and GLP-1 agonists on different areas. So if we look at blood vessels, first of all, decreases your blood pressure. We think about your GI tract. So we spoke about the decreased gastric emptying, the slowing down of food and the movement. This decreased chylomicron secretion, that basically means that, I guess, there's less fat circulating and things like that. And because of, we'll talk about side effects in a bit more detail later, but because of the close interlinkage between your GLP-1 and your GI tract, a lot of the main side effects of these agonists are going to be taking place in your GI tract. So we'll go into a bit more detail on that in a bit. And then we can talk about the effects on the pancreas as well. So remember we spoke about your decreased glucagon, increased insulin, and also we spoke about a little bit of the effect on your brain. So in terms of decreasing appetite, signaling those feelings of fullness. And yeah, this is another diagram talking a bit more about how all these different things contribute towards protecting your heart. So in the previous diagram, it was just talking about the general effects in the blood vessels, GI tract, pancreas, and brain. But now if we look at this next diagram, it kind of highlights a bit more how these different factors contribute towards cardioprotection. So decreased inflammation is kind of a common theme. The decreased appetite mean that there's less fat kind of circulating, because obviously if you're decreasing caloric intake, decreased fat circulating in your body, and that helps your liver. That obviously decreases your body weight. So yeah, essentially a lot of different things work together to help protect your heart because of this GLP-1 medication. Okay. Next, let's talk a bit more about the problems with your GLP-1 medication. So Firstly, let's talk about side effects. So on the side, on the right side, I basically just put some of the outrageous headlines I came across when I was looking at kind of the side effects and how people are kind of receiving this medication. So a lot of these are a little bit extreme because not all of the news that's put out is kind of research based, evidence based. There might just be one or two anecdotes from individual people or celebrities that they have managed to make into a news story. So things like Ozempic tongue, Ozempic feet, Ozempic teeth, like these are all quite fantastical kind of events that don't really happen in everyone. As I said, the most common symptoms are your GI symptoms. But there is a little bit of kind of explanation for why these other symptoms happen. But the way that they're kind of dramatized in the media is part of the reason why there is so much misinformation about Ozempic and the other GLP-1 receptor agonist medications. So if we start with Ozempic face, so that is basically due to um obviously normally you wouldn't lose this much weight in a small amount of time as you would with Ozempic or another GLP-1 receptor agonist medication. Um, but when you have this rapid weight loss from taking Ozempic, then you can have like a hollow look in your face or wrinkles or sunken eyes. And if you were losing weight more slowly, these kind of effects wouldn't really be as noticeable as they would be if you rapidly lost weight, like you would with a GLP-1 receptor agonist medicine. So that is where Ozempic face comes from. Ozempic hands, Ozempic teeth, I'm not too sure about. I feel like they're a little bit extreme. But if we start to think about the GI symptoms that are the most common, then that's thinking about things like nausea, vomiting, diarrhea, constipation. And that's obviously because you have that slowing of the GI tract, you have that reduced gastric emptying, which means that obviously, you're going to have some sort of constipation because things are getting stuck. There's reduced kind of movement through the system and the discomfort, feeling of fullness that can lead to things like nausea. So, because most of this kind of action is happening in your GI tract, which leads to things like reduced absorption of glucose, reduced absorption of lipids, um, because most of the action is happening in your GI tract anyway, that's why you have the most common symptoms there. But they can be kind of mitigated, worked around by making sure that you're kind of phasing yourself in. So you don't just straight away jump onto the most increased dose, the most extreme dose, kind of phase it in slowly so your body has time to adjust to the medication. And also thinking about things like making sure that the dose is appropriate for you. If you have a sensitive GI tract, then maybe taking a medication which doesn't have such severe symptoms. So, considering a lot of different aspects when choosing the medication and also thinking about how you're administering it and the dosing as well. So then we can think about optic neuropathy next. And this is basically what happens when the blood flow to your optic nerve is affected, and it can cause kind of like sudden blindness, which obviously can be quite scary. And the reason that this might be caused by Ozempic or a GLP-1 receptor agonist medication is because you have that kind of effect on the blood vessels. So when we spoke about blood pressure, we spoke about them vasodilating, and things like that. And also the blood sugar changes in combination with the vasodilation can cause issues in terms of affecting your optic nerve and the blood flow towards your optic nerve. And in terms of optic neuropathy as a whole, you do have those pre-existing risk factors of type 2 diabetes, hypertension, and people who will be taking these drugs often will have those risk factors anyway. So they have a higher chance of developing optic neuropathy from the get-go. But the effects of the GLP-1 does kind of make those a little bit worse and increase your chances of developing optic neuropathy, which is quite scary. But a lot more research is needed because you can't always say that correlation is the same as causation. Because I just mentioned, like, they have those risk factors for optic neuropathy anyway. So you can't say that this medication is causing the optic neuropathy when it might be caused from the pre-existing issues that they have in terms of hypertension, type 2 diabetes, and you can't directly say, well, because they're taking this medication, that's why it's a side effect. I hope that makes sense. And then if we move on to thinking about slightly more extreme gastrointestinal symptoms, so you have like your normal, not normal, but like milder ones, like nausea, vomiting, diarrhea, constipation. But then you have the more extreme ones like pancreatitis, inflammation of the pancreas, gastroparesis, which is basically stomach paralysis. And we spoke about the reduced gastric emptying. This is like very extreme reduced gastric emptying. So the stomach muscles become so weak that there is basically no movement going on. And that is quite an extreme complication of these medications, but they can happen. And another one is bowel obstruction. So basically, you have a either nervous or muscular issue, which means that you're not able to control movement through the bowel. Similar to kind of gastroparesis, except that's more the stomach, and this is more your bowels. But yeah, as I said, it's minimized by starting on a lower dose and gradually increasing so your body gets used to it and accustomed to this medication. Avoiding high fat or sugary foods and eating smaller, more frequent meals. These are all kind of things that you would instruct your patients if you're prescribing it. But the main issue here is that people are taking this medication without actually having any sort of insight into how it works or the side effects or how to deal with the side effects or how to administer it to themselves. And this is because of the kind of celebrity hype around it, because of the social media kind of hype about it as well, which is leading to misuse. And this is basically what's happening is that a lot of patients without obese kind of indications or type 2 diabetes to the extent at which they would require this medication are taking this medication without being approved. So if you think about it, in type 2 diabetes, you often have a high blood sugar, but the GLP-1 receptor agonist medication brings that down to a normal baseline level because of that increased insulin. If you already have normal blood sugar and you bring it down even further, that's going to cause hypoglycemia if you're not a diabetic patient. So when these celebrities, when these people who want to kind of jump on this trend of taking this medication, taking this drug as a miracle weight loss pill, they risk having these hypoglycemic episodes where their blood sugar drops so low it can be quite dangerous, because they're not aware of the actual implications of this medication systemically. Um, so yeah, having this unapproved use also increases other side effects like gastrointestinal ones, increases risk of things like those more extreme gastrointestinal symptoms. And it also increases demand. So because you have so many people trying to get their hands on this medication, trying to get access for this medication, that means that the people who actually do need it are unable to access it because of these shortages, because of this kind of counterfeit business going on, where there are fakes, adulterated kind of medication available on the market. And yeah, again, driven by celebrities, anecdotal hype on social media, which is kind of unjustified and really quite dangerous because a lot of people are trying it without knowing the reality of the medication. Um, Another side effect of having those kind of GI symptoms when, you're not actually obese or a diabetic patient is that you can become severely dehydrated. So again, that can cause so many other issues. But another issue that is kind of arising from the fact that there is a shortage because everyone's trying to get their hands on GLP-1 receptor agonists at the same time is that there are falsified medications which actually contain insulin. So as you can imagine, that's going to decrease your blood sugar very rapidly. And because people are under the impression that they're injecting Ozempic or something into themselves, but they're actually counterfeit pens that actually contain insulin. And this can become very dangerous, as you can see in this example of this woman who was under the impression she was using insulin. Sorry, under the impression she was using Ozempic, but she ordered it from an online beauty company that wasn't, regulated in any way, and she injected herself with insulin, put herself into a like diabetic coma essentially, because what she injected herself was a very fast-acting insulin, dropped her blood sugar all the way, induced her into a diabetic coma, and she collapsed, suffered seizures after administering the injection, and had to be taken straight to hospital. But the danger was this happened in 2023. 3 years prior, when GLP-1 receptor agonist medication wasn't that common in terms of use for weight loss cosmetically, but also in prescribing. Back in 2020, it was a lot easier to get your hands on actual Ozempic. So there was less demand. She got it from a legitimate online pharmacy, and it did help her lose weight because it was actually, acting as a weight loss medication. And then 3 years down the line, there's this newfound demand for Ozempic and she wants to get her hands on it again. She can't get her hands on real Ozempic, so she orders from an unregulated online beauty company, accidentally injects herself with insulin, and then becomes very acutely unwell due to this hypoglycemia induced by this insulin. So, that is kind of an example of what is going on quite commonly due to this increased demand for your GLP-1 receptor agonist medication. So kind of going on a bit further from the shortages, it's portrayed as a quick weight loss solution, which is kind of driving this whole demand because everyone is obviously looking at social media, comparing themselves, seeing that it works, which it does work. It just causes a lot of side effects that people don't know about. So that is kind of causing increased demand, shortages for people who actually do need it. And for the last 2 years, it has been in shortage, which has meant that in the US especially, they've kind of permitted people, they call them compounders, and they allow them to dispense non-approved drugs to mimic the ones that are experiencing a shortage. So, for example, Wegovy and Ozempic, they were allowed to be produced non-officially by the not official manufacturers to kind of mimic the same effects in order to compensate for the fact that there's a shortage going on nationally. So now that the shortage is over and the US kind of government are like, well, you can't have this kind of fake medication going on anymore, they're suing the government and saying, well, we need our money from somewhere. So they want to keep on producing this unofficial medication. So obviously that's dangerous. Similar situations to the one we just discussed are going to arise. And in terms of healthcare disparities, so we often talk about kind of postcode lottery and things like that. But in this case, what's happening is that the wealthier celebrities and people who don't actually need the medication usually, they're able to put more money into it and get the legitimate medication than the people who may need it more, from a clinical perspective, are unable to have access to it because the prices have increased so much due to the demand. So that's kind of deepening those healthcare disparities and making it unfair for people who actually do need it clinically, they're not able to access it. So that is a problem because wealthier people are using the drugs, legitimate drugs for non-therapeutic purposes. They're using it for cosmetic purposes instead. And yeah, that obviously disproportionately affects those people who actually do suffer from type 2 diabetes, actually do suffer from obesity, and do need the medication to manage their symptoms day to day. So hopefully this shortage stays gone. It has ended after 2 years. It's no longer in shortage technically, but obviously there's a lot of issues arising from this kind of fake medication that has become available quite easily due to the shortage when it happened. These compounders started producing it in large amounts. Okay, so now lastly, we'll talk about the GLP-1 receptor agonists and going forward, what can we expect to see in this field? So there are kind of three main things I'm going to talk about in terms of the dual and triple agonist. So we already have Mounjaro, which we spoke about as a dual agonist targeting your GLP-1 and GIP, works together to make a much more suitable, much more accessible, not accessible, but like effective weight loss medication. It's in trials it's shown that it is more effective for weight loss. They're looking at producing a triple agonist, which is going to target GLP-1, GIP, and glucagon receptors. And this is because your glucagon may actually enhance your energy expenditure. So, alongside all of the effects we've spoken about so far, by introducing glucagon, it's also going to mean that by basically increasing your metabolic rate, you're going to burn more calories in a sense. So, that obviously increases your weight loss efficiency. And then another really important thing to discuss is education. So thinking about emphasizing the importance of those lifestyle changes alongside taking the medication for weight loss, and type 2 diabetes, just so you don't become dependent on it and you don't bounce back to the weight that you were before after coming off the medication. And obviously trying to do things naturally is definitely better. Prevention is better than cure. And then just generally on social media, in basically just common knowledge, trying to break the impression that these drugs are a quick fix for weight loss, because obviously you do tend to bounce back. They do come with a lot of side effects. No one who's taking them for aesthetic purposes really knows what the actual effect is on their body. So by combating this misinformation on social media, is really going to make sure that people kind of come out of this impression that it is basically like a magic pill, which it isn't, obviously, as we know. And also tackling counterfeit availability is going to mean that people, like that woman we discussed, don't end up in hyperglycemic episodes from injecting themselves with insulin under the label of it being Ozempic or some other GLP-1 receptor agonist medicine. So tackling its availability is going to be really important in making sure that people who are trying to access it without prescription, they're able to access something safe enough. Um, and then the last thing that I want to discuss in terms of the future, we kind of touched on it a little bit earlier in terms of the other uses for this medication and kind of the untapped potential in working out how it might influence other systems. So we spoke about the cardiovascular implications in terms of improving hypertension, improving, it can also lower cholesterol sometimes. And then we spoke about all the other things that go on with the link between the GLP and the cardiovascular system earlier. And then thinking about renal health, that's your kidney. We spoke about making sure that you're kind of reducing that stress on the kidney by decreasing your blood pressure, because obviously they're quite interlinked. It slows the progression of chronic kidney disease, GLP-1 receptor agonists also in the kidney. So again, very early days, a lot more research needs to be done into the actual effects of GLP-1 receptor agonists on these different systems. But they are saying things like it might slow progression of CKD, it reduces oxidative stress and inflammation in the kidneys. And because having these risk factors like high blood sugar, high blood pressure, and being obese, these risk factors do contribute to a lot of different things. So these GLP-1 medications bring those down, and overall, that improves the function of many different systems within the body. And then if we think about liver health, we spoke about like reducing liver fat because of that kind of improved lipid metabolism, and also you're losing weight, so that fat content decreases anyway. And this is really important in the treatment of non-alcoholic fatty liver disease, which is kind of becoming more and more prominent because of people's diets. They're higher in fat, higher in sugar from a very young age, which means that they're developing non-alcoholic fatty liver disease. It used to be just alcoholic fatty liver disease because you would develop it from having a lot of alcohol over the course of your life in older people. But now it's becoming more prominent in younger children, not because of alcohol, because of their diet. So by reducing this liver fat, it can contribute towards treating potentially this non-alcoholic fatty liver disease in children. And then lastly, if we talk about the brain, there's early evidence to suggest that it might protect cells in the brain from damage, and that slows the progression of neurodegenerative diseases like Alzheimer's, Parkinson's. So that would really make an effect in a lot of people's lives if that did end up being viable as a treatment for these diseases. And again, that's because of the reduced inflammation, the reduced oxidative stress, and also the blood is very dependent on glucose. So by enhancing this insulin sensitivity, it kind of maintains the brain's ability to use the glucose effectively. So thank you for listening. I think we have a few minutes to answer questions.
Before you leave and before we go on to questions, I have some interview style stuff that I think may be very useful. So do stick around before leaving and give me 30 seconds to put the same on the chat. But we are going to be, I'll actually just start to show you the first one now. So thank you so much, Akshita, for that presentation. Let me let you guys quickly put a quick thank you in the chat. And then I'm going to show you some questions we can give a try just before we finish off. While you're taking a look at this diagram, I'm going to ask you about it in a second. I will spam Yuka experts and V2 to make sure some join. Okay, Akshita, can you see all the nice comments?
Yeah.
Great work. So, let's have a look at this graph. And so now we know all about semaglutide. And so what is semaglutide? What kind of drug is it? Hopefully we know by now. Hmm. Did we talk about it as under a brand name? Maybe. So what kind of drug do we know semaglutide to be? Ozempic, right. And what does Ozempic do? Hopefully we've been listening. Yeah, exactly. So GLP-1 agonist helps with type 2 diabetes, helps with weight management. Okay, so we did listen. Amazing. So if we take a look at this graph here, and if anyone's feeling brave, maybe put your hand up. And if you'd like to describe and explain, so firstly, just describe what you can see, and then explain what it might mean for use of these drugs. What could be some of the implications? Why might it be happening? So even if you just want to describe, you don't want to explain, that's okay too. Anyone who's brave, feel free to put your hand up. So we want to describe and explain what we can see. Any volunteers? And I can give you a minute if you want a minute first. And by the way, Akshitas, thank you so much for sticking around. If you do need to go, then absolutely don't worry about staying for this, as this is just something extra I added in without telling you. But if you'd like to stay, then you're most welcome.
No, that's fine. I think I will probably have to leave now, but
No
it
worries.
was so lovely speaking to everyone, and I hope you guys find it useful. And yeah, I'll hopefully see you guys at some point again. So,
Thank you so
bye.
much. Yeah, I think they really loved your talk. So let's see if we can arrange another one soon. But
Perfect.
yeah, bye
Thank you
for
so
now.
much.
Thank
Bye.
you. Okay, I think first was Aka Achu, if I'm pronouncing your name right, whenever you're ready.
First of all, the both of them, the body weight decreases during the treatment phase, and the semaglutide decreases much more rapidly than the placebo. And after the treatment on the off-treatment extension phase, both of them have a body weight increase. And again, the semaglutide is way more dramatic and increases faster than the placebo arm, but the increase is very small compared to the loss that they first faced.
Amazing. So if we start by talking about the describe, I think you did a really great job. So you talked about the trend to start with and how both of them were decreasing, one to a greater extent. And you talked about how both of them were regaining, but not all of the weight was regained. Now, how I would approach this, you've got exactly the right stuff. I would maybe just change the structure a little bit. So I would start by saying, what can I see? Well, I can say here a line graph. And on the x-axis, we're looking at time since randomization. And on the y-axis, we're looking at a percentage change in body weight. And so what we're looking at is a graph showing how the participant's body weight has changed over time when either on semaglutide, which is shown in blue, or placebo, which is shown in gray. Then you'd say exactly what you said, which was perfect. So just in terms of a structure, maybe like what can we see? X-axis, y-axis, then go into it. But otherwise perfect. So as you said, both of them saw some weight loss. Semaglutide saw more weight loss. Clearly, it works. But what happens here? So at this point, we are off treatment. We have stopped the treatment. And as you can see, a lot of the weight has been very quickly regained. And so, why might that be the case? What could it mean? What do we think? And what could be the implications? Anyone else? Someone else had their hand up. So, really good answer for the describe part. Let's maybe try the explain part. What's going on and why? So, what does this graph tell you? No worries if, yeah, Hanan, go for it.
Okay, so maybe this could be due to the placebo effect. Maybe that would show that the placebo is having a better. It's showing. It showed worse results. It showed better. Wait. It showed worse results than one of the actual of the 2024.
Okay, amazing. So you've just explained a different part, but that's also very valid. And so we'll talk about this in a second. But as you've mentioned, even without kind of using semaglutide, we can see some kind of placebo effect. And so it's definitely not as effective as the semaglutide. So Ozempic does work, as we know. But there has been more weight loss when on this placebo compared to when off it. And so there might be some kind of reason for that. As you said, the placebo effect, maybe people are more engaged with all these meetings with their doctors. They're actually more motivated to lose weight. So there could be lots of reasons. And as you said, the placebo effect might be one of them with the placebo arm. So totally right. But if we think about maybe this here, what we can see is that as patients are taken off Ozempic or off semaglutide, they very quickly are found to regain the weight. So notice how, on average, they had lost what, about 20% of their body weight, more than 15 kilograms from baseline, but they regained about 10 kilograms more than that within just a matter of weeks. So this is what, 70 weeks, this is 120, that's about a year. In 1 year after going off Ozempic, you can see these patients have regained 10 or 15 kilograms. So what we can see is that these drugs, as soon as they're discontinued, any effect that they had is very short-lived. That's your explaining part. That's what could be happening. And what is the downside of that? Well, it means that these drugs may have to be taken lifelong because as soon as you discontinue them, patients do very quickly regain the weight. So that would be kind of your describe half that someone did perfectly. And then your explain half would be, well, the effect of these drugs is short-lived. And as soon as you stop them, patients may regain the weight. And what is the take home? Well, it's super important that we also give patients lifestyle advice. So yes, they can use these drugs, and yes, they may be very helpful. But if patients are not given the right lifestyle advice, these drugs in isolation are not going to cause kind of lasting change in weight unless they are prescribed for kind of for life. And is this only for Oxford interviews? I would say not necessarily. Other unis like Birmingham do still give you data analysis, describe, and explain. But this is probably a more scientific question. At a lot of other interviews, you might still be describing a graph, but it might be a bit less scientific. So it just depends how tricky it is. But other interviews besides Oxbridge do still have graphs. Okay, let's try another one. So we have here Mr. Adil Khan. He is 43 years old. He has a BMI of 34.5. So what do we think? Is 34.5 a very good BMI? Is he healthy? What might he be experiencing? So he's an obese patient, yeah, and he's got many comorbidities. So he's got hypertension, prediabetes, depression, lots of things he's struggling with. And he's also socially isolated. He has low mood, financial stress. So he's facing a lot of problems. And we've got them summarized here. What are some of these social factors? So he's living alone, history of emotional eating, he's a smoker, he's struggled with his weight loss in the past. So Mr. Khan has gone to his GP appointment and he has asked for semaglutide, this drug that we've just talked about. And he's brought some articles from the news. He insists this is exactly what I want. There's nothing else that works for me. I need this medication. Now, his GP knows what are the criteria for this drug to be prescribed. And well, you need to have a BMI of more than 35 for this to likely to be a good idea. You also alternatively need to be diabetic. There are different options. But this patient does not meet the criteria for this drug to be prescribed on the NHS. Now, one option is that this patient goes privately, or there are perhaps some other things that this doctor could recommend. But as of right now, the doctor is not able to prescribe the drug. So, what kind of things would you, as a doctor, and you don't need to know the scientific or the clinical aspects, but what kind of things do you think you might say to the patient? And what kind of things do you think might you be able to recommend? So, how would you deal with agitated, stressed Mr. Khan, who really wants semaglutide, but you are not able to prescribe it to him? What kind of things would you say? And so, hand up as soon as you have any ideas. Now, this person is clearly struggling. What kind of things could we put in place? Let's have Ace first.
First of all, you would recommend therapy for them, maybe, to deal with the more mental issues that he has, like depression and the low self-esteem. And then you would try and explain to him why it is that he can't have the drug and why it's possibly more bad for him than it is good. And you obviously you can't make him not buy the illegal version, but not the illegal version, the like the more like the one with the more side effects, but you'd have to try and tell him that they do have side effects and he could be buying something that's worse for him in the long run.
Amazing. So the first thing we might want to talk about, exactly right, we might want to deal with some of these social factors he's experiencing. Now, I know you mentioned mental issues. I probably wouldn't recommend using that language. I know you were very much on the spot, but I would try and refer to the stuff that was given to you in the question. So imagine there was a pre-reading. You would talk about, okay, this patient is experiencing depression, he's experiencing low mood and social isolation, and we would try and put support in place to help him deal with that. So I wouldn't necessarily call it mental issues, but I'm sure you didn't mean that in a bad way. And so you could be quite specific what you recommend. Definitely therapy, yes, that could be an option. But also, could he have a referral to maybe psychiatry? Could we help him with his social isolation? Could we do some kind of social prescribing? So could we recommend that he does anything that will help him with his social isolation? Do we know if any support groups are around? Do we know of any activities that the GP surgery is able to recommend? And many GP surgeries now, they have something called like a social prescribing link worker, and they're responsible just for trying to help patients deal with social issues like this. And so they could even give advice on like exercise clubs they can join, social outings, local organizations, charities that he could volunteer with, stuff that he could do instead. So that might help with some of the low mood side of things. You then talked about downsides. I completely agree. So definitely explain to him what some of the downsides could be, some of these side effects, why this drug is not necessarily perfect, especially as we think about just what we saw now in the graph, how the weight is all regained quite quickly. What about some of the other things here? So we know, for example, that he has suspected sleep apnea and he also has back pain, as well as emotional eating and financial stress. Do you think any of these things could contribute to his fatigue, his low self-esteem, the fact that maybe he is gaining weight? MK13, any thoughts? Could we offer some advice based on that?
So I was thinking in terms of the fact that he's a smoker. So we know that he's not allowed to use Ozempic or to use a drug that's been recommended. However, we could emulate ideas that could like reduce blood pressure, for example, like maybe weaning him off smoking, like maybe using nicotine patches or nicotine chewing gums. Obviously recommending dietary changes, but also maybe looking into his social history or his lifestyle. So his work, he may be living a sedentary lifestyle. So it's putting implications and ways that he could be more active, getting his steps in, socializing more with people, finding the root cause as to why he's not socializing, which can be achieved through obviously referring him to like a therapist.
Really, really nice. So all the ideas you've talked about, they could come under the keywords of kind of holistic care. And so I really like exactly what you've said, talking about the social factors, how we can maybe make a change to some of them, taking the broader history and the fact that we know he's struggled with weight loss in the past. Well, why don't we have a chat with him about what specifically didn't work for him then? And why does he think that maybe only Ozempic can work? So is it that when he was with dietitians, maybe their advice was very strict, very quickly, and he couldn't do that right away? Could we try maybe a more easier plan that he could follow? What maybe didn't work for him about Slimming World? Could we try an alternative that might be more effective? So all that kind of thing, that holistic side, and exactly as you said, deal with some of the other things we're dealing with here. So what about the financial stress he's facing? Is he able to afford healthy, nutritious food? Is that maybe one of the problems? Would support with that be useful? Does he need to be referred to something like a food bank? Could that be useful? Could that mean that he has access to more nutritious food? Could that be beneficial? So definitely let's think about that side of things. Fatigue, that might be quite closely associated to his weight gain because we know that there's a correlation between kind of poor sleep hours and weight gain, cardiovascular disease. And we know that he's suspected with sleep apnea. So maybe we could try and help him with that. Likewise with the back pain. If someone is in pain, they're probably not going to be very active. That could lead to his weight problems. How about how we're going to respond to him? So we're going to make sure we're super empathetic. We're communicating sensitively. We validate his concerns. I understand where you're coming from. Or maybe don't say I understand, but I empathize with where you're coming from, as maybe you don't fully understand as a doctor. So make sure you phrase that sensitively, but you do show empathy. You listen to him. So, like I said, what are his kind of ideas, concerns, and expectations about this? What would he like to happen? What is he worried about? And how can we maybe help with that? So allow the patient to talk for a large part of this consultation. And finally, what I would say is kind of we do have the idea of referring him privately. That is something that GPs are able to do. And we could discuss whether a private consultation may be an option for him. But again, kind of keep in mind what are the social factors here. So he is facing kind of financial stress. He's probably not going to be able to afford expensive medicines, especially as we know, as soon as you discontinue these medicines, you regain a lot of the weight. So we're going to be trying to emphasize some of these lifestyle factors. So empathy, I see how hard it's been for him. Explore what is he facing? What can we do about it? Definitely emphasize that given his circumstances, we are not able to prescribe to him right now, giving his BMI. Make sure you phrase that sensitively. Like, for example, we saw that there was a cutoff of 35. He's on 34 point something. Do not encourage him to increase his weight to 35 so that he then becomes eligible. That would be a very bad idea, but like a perverse incentive. So make sure you do that sensitively. Talk about what are the alternatives. Now, you wouldn't need to know about specifics. There are other medicines out there, but you could say explore whether there are any alternatives that might work for him. Lifestyle support, talk about what can you do now, and do discuss private options that they exist, but talk about the downsides, talk about the side effects. So very much a holistic approach, not just thinking about kind of, no, you can't have semaglutide, but what can you have instead? Why might that be helpful? So does that make sense? And so do you see how we might answer a question like this, even if we know nothing about the topic? So even if we don't know about Ozempic at all, how can we support it? And we've got some good keywords there, shared decision making. So how can we work with him to see what he can do? So yes, we can't prescribe these medicines because it's not allowed, but how can we work with him to see what's going to be a good idea? And would they use terms like semaglutide? Probably not. The only reason I use that is because you've just been listening for an hour all about that drug. So I thought you probably know a bit about it. But usually they'll use it in like quite simple and accessible terms. So they might talk about kind of GLP-1 agonists, and they might even give you a summary at the top. So what is a GLP-1 agonist? This is what they do. This is the downside. Let's now answer the question. So they wouldn't expect kind of any high-level knowledge. And finally, isn't paternalistic bad? Yes, paternalistic is bad. So we're shifting towards a less paternalistic side of care. Who is pater? Pater is the father. So a paternalistic style of care is like you're treating your patient like a small child. I am the doctor, I know best, like a father knows best for the son. So a paternalistic style is I will tell you what to do. I am the doctor, I know what should happen, you should listen to me. What is better nowadays? Working in partnership with patients, working as a team. So listening to their concerns, what works for them, what doesn't work for them. Make shared decisions. So respect patient autonomy. So we're trying to be less paternalistic. We can talk about it as patient as a partner model. We can talk about it as shared decision making. That's what we should do instead. Working in partnership with patients, not paternalism. But if you don't understand the word paternalistic, don't use that in interview. You can just describe what you mean. So you can say, don't just tell patients what to do, work with them. Don't use any words that you don't understand if you can just kind of rephrase or explain. Are there any instances when we should be paternalistic as a doctor? I would say pretty much no. There are times as a doctor when you'll need to provide information so patients understand, and there are times when you'll need to listen. But even when you're providing information, you should do it in like less of a didactic, less of a paternalistic way, not just a teachy way. You should make sure you're providing the information in a way that people will understand and that you have a discussion about it. Yeah, collaborative would be a good word. I like collaborative, someone has put. So in a paternalistic approach, no, a patient wouldn't have a say. But obviously there's a spectrum, so you could be totally paternalistic, totally collaborative. And are there times when you would go against someone who has power of attorney? Yes, it's possible. Usually you'd involve the courts and they could then withdraw the power of attorney. But it's quite rare that you would overrule power of attorney unless you thought that the patient was at risk of harm. So not just because if you disagree with their decision, but if you think that the patient is at risk of serious harm, then yes. And do you get a certificate for these? Yes, you do. So I'm going to send two forms in the chat now. The first form is going to be for your GLP-1. That is the one to get certificates. So this for certificates, that's this one. We also have a separate form for chemistry feedback. So this is the form to do certificates, chemistry feedback. Can I send that document? Which document? The one where I had the notes about that consultation thing for Adil Khan? Yeah, I can send that. So that was just a list of points that I thought we could talk about. I wouldn't worry too much about the specifics here. It's just making sure you know the ideas. So, like respecting the patient's choices, how can we kind of work on their social circumstances? How can we work on something that's good for them? How can we look at what was the barrier for them the last time? What can we change for this time? I wouldn't try and learn like very specific stuff for this question, like say Orlistat. I don't think that specific name matters as much as the ideas here. So talking about alternatives, being transparent, clearly explaining what's going on, being empathetic, that sort of thing. I think we all had the right idea though. So hopefully going to become good doctors in the future, not ones that ignore their patients and just tell them what to do. Right. I think that is pretty much everything. So make sure we do fill in those forms, please. The one for the A levels and the one for the GLP-1 drugs. So it'll take you 2 seconds. The one for the A levels, you don't even have to put your name or anything. It's literally just press how many stars. The one for GLP-1, you probably do want to put your details so you get a certificate. So I'll send those again. Are there recordings? Yes, there are recordings. To make sure you always get access to the recordings, you should be on one of our group chats called UCAT Experts or UCAT Experts V2. Is there anyone here who is not on UCAT Experts or UCAT Experts V2? Are we doing more case examples? Yeah, we are. Not today because it's 7:40 now, but we will be doing more case examples.